So hello everyone and welcome to case 36 of this case discussion series, and today we'll be discussing a very interesting case. It's also a spotter case. Here we have a 20-year-old female who came with history of seizures since the past 1 year now, and this is the MRI picture of this patient. These are the coronal images, T1 post contrast images, and we are going from front to back. So this is the cerebellum and these are the occipital lobes which are coming. So in the left occipital region, posteriorly, what we see is there is a bubbly lesion which is not enhancing on these post contrast images. This bubbly lesion which is seen in the left occipital cortex, which is very well defined, and these are the T2 weighted images where we can see that it is T2 hyper intense. So the flare images I don't have here, but the flare images look like this, of the cortical based lesion with peripheral rim of hyperintensity. Bubbly lesion, cortical based with peripheral rim of hyperintensity. There is only one diagnosis, and that is dysembryoplastic neuroepithelial tumor. So this is a report I had given. There is a cortical based T2 hyperintense bubbly appearing mass in the left occipital lobe. In the coronal flare images, it showed characteristic ring-like hyperintense signal, giving the bright rim sign, which I'll be discussing later in my slides. No perifocal edema or no contrast enhancement was present, which was suggestive of dysembryoplastic neuroepithelial tumor of the left occipital region. So these tumors are actually long-term epilepsy associated tumors. So dysembryoblastic neuroepithelial tumors are benign WHO grade 1 slow growing glioneuronal tumors arising from either cortex or deep gray matter, and they are considered to be a part of long term epilepsy associated tumors, LEATs. So what are the other tumors that are included in the long term epilepsy associated tumors? They include PXA, that is pleomorphic xanthoastrocytoma, MVNTs, that is multivacuolating neuroepithelial tumors, DNETs, and gangliogliomas. So I'll be discussing all these tumors later in my slides because they are also differentials for DNET. A vast majority of DNETs are centered in the cortical gray matter. This is very important. They are usually cortical tumors arising from secondary germinal layers and are frequently associated with cortical dysplasia. Although in this particular case it was not seen, and they characteristically cause intractable focal seizures. Coming to the very characteristic sign which is seen in DNET, that is the bright rim sign. The bright rim sign, also called the hyperintense ring sign, which was seen on the flare images, is described frequently in DNET but can be seen in other tumors as well. So here we can see that the T2 hyperintense tumor, actually the rim of this T2 hyperintense tumor is not suppressed on flare images. It remains hyperintense, giving the bright rim sign which is characteristic for this particular tumor. But it is very much similar looking to a T2 flare mismatch sign, a sign of low grade astrocytomas, that is IDH mutant astrocytomas. So this is the T2 flare mismatch sign of astrocytoma. Astrocytomas typically do not appear bubbly in appearance and they are not usually cortical based. And secondly, they'll have a choline peak on MRS, which will not be seen in DNETs. So bright rim sign is described as a well-defined rim of high intense signal around the DNET on flare sequences. The T2 and the flare hyperintense ring, whether complete or incomplete, is fairly sensitive and specific for DNET. And a very important thing that has to be noted is on post-op imaging, this sign can be helpful clue for residual tumor or tumor recurrence. So the differentials for a DNET will include other cortical tumors like ganglioglioma. So this is a case of ganglioglioma, which is also cortical based tumor. But in ganglioglioma, it shows intense post-contrast enhancement, and about calcification is seen in 50% of the cases, and there is no bubbly appearance as such, which is characteristic for DNET. Then PXA, that pleomorphic xanthoastrocytoma. This is a case of PXA. PXA usually shows a dural tail sign, and post contrast enhancement, which is not seen in DNET. Then coming to diffuse low grade astrocytoma, as I already discussed, where we see T2 flare mismatch sign, it does not usually have a bubbly appearance and will show a choline peak on MRS. And oligodendroglioma is also a cortical based tumor, which is IDH mutant 1p19q co-deleted. It usually shows contrast enhancement and has a lot of calcifications. Coming to MVNT, multinodular vacuolating neuronal tumors, they're usually juxtacortical white matter rather than the cortex, but they have that soap bubbly appearance. But they do not give a T2 the flare hyperintense rim sign, which is characteristic for DNET. Then the perivascular spaces or VR spaces, that is Richter-Robin spaces, which are usually enlarged perivascular spaces, are seen in the white matter and are elongated along the vessel axis, and they fully attenuate on the flare, do not show any bright rim sign.